Good evening friends, welcome to my channel Critical Care Basics. In today's lecture we are going to talk about acute pancreatitis. So we had a patient recently with acute pancreatitis, so I just thought we could make a presentation on acute pancreatitis that could help all the doctors and nurses working in critical care. So as you can see from this diagram, the cystic duct and the bile duct together form common bile duct, which comes behind the pancreas, and it combines with the pancreatic duct to open together at the ampulla of Vater. And whenever there is a stone coming from the common bile duct, and if it gets impacted at this point, it causes outflow obstruction of the pancreatic juice, and the pancreatic juice, as you know, contains enzymes to digest tissues. So the enzymes start digesting pancreas itself, causing what is called as pancreatic inflammation or acute pancreatitis. So this is the most common cause of acute pancreatitis. The incidence of acute pancreatitis ranges from 20 to 80 per 1 lakh, and the prevalence of chronic pancreatitis is about 120 to 143 per 1 lakh patients, and two most common causes are gallstone disease and alcohol. Prevalence in India is 8.6 to 8% per lakh in men and women respectively. The overall mortality of pancreatitis is 1%, but it can be as high as 20 to 40% in patient with severe pancreatitis. We will come to what is severe pancreatitis. So in severe pancreatitis, the mortality can be very high with necrosis and organ failure. There are two peaks of mortality. One is early and the second one is late phase. The early peak in the mortality is caused by a sterile inflammatory process starting from the pancreas and progressing to what is called as systemic inflammatory response syndrome, SIRS, with a mortality of about 50%. And a late peak of mortality is usually secondary to infections of the pancreatic and peripancreatic necrotic debris. Presentation. The typically acute pancreatitis presents with acute onset persistent severe epigastric and left upper quadrant pain. In some patients the pain also may be in right upper quadrant, but the more common is the left upper quadrant. In gallstone pancreatitis, the pain is well localized and onset of pain is rapid, reaching maximum in intensity in about 10 to 20 minutes. While in patient with pancreatitis due to metabolic causes or alcohol or hereditary pancreatitis, the onset of pain may be less abrupt and the pain may be more diffuse, that is poorly localized. In 50% of patients, the pain radiates to the back and the pain persists for several hours or days and may be partially relieved by sitting up. So sometimes you can confuse it with pericarditis because the pain gets relieved a little by sitting up. 90% of patients have associated nausea and vomiting. So this can also be confused with epigastric pain, and nausea and vomiting can be a presentation of ischemic heart disease or acute coronary syndrome. So pancreatitis can be mimic of acute coronary event also. Patient with severe acute pancreatitis may have dyspnea. This dyspnea could be due to diaphragmatic inflammation or pleural effusion, or if there is severe organ dysfunction, could be due to ARDS. Sometimes approximately in 5 to 10% of patients with acute severe pancreatitis, they may have a painless disease and have unexplained hypotension as the main presentation. Example, patient with postoperative pancreatitis or critically ill patients, or in patient with dialysis or organophosphorus poisoning. On physical examination, there is tenderness in the epigastrium. Patient may have abdominal distension or decreased bowel sounds. Patient may have icterus if there is gallstone impaction in the bile duct and obstructive jaundice. Patient with severe pancreatitis may have SIRS, fever, tachycardia, hypoxemia and hypotension. These are the two signs: ecchymotic discoloration below the umbilicus, what is called as Cullen's sign, and ecchymotic discoloration in the flanks is called Gray Turner's sign. Sometimes patient present with what is called as pancreatitis, polyarthritis and panicolitis. Panicolitis means the inflammation of the subcutaneous fat. So this is the inflammation of subcutaneous fat plus there is arthritis and there is pancreatitis. So this is triple P, pancreatitis, polyarthritis, panicolitis syndrome. Patient may also have findings suggestive of the underlying etiology. For example, in patient with alcoholic pancreatitis, they may have hepatomegaly. If the patient has hyperlipidemic pancreatitis, then they could have xanthomas, and if the patient has mumps, they could have parotid swelling. Coming to the etiology, the most common etiology, as we have already discussed, is gallstones, 40 to 70%. The next comes alcohol. Third comes hypertriglyceridemia. It is reasonably uncommon, from 1 to 14%. This happens when the triglyceride levels are persistently above 1000 milligram per deciliter, and acquired causes of hypertriglyceridemia include obesity, diabetes mellitus, hypothyroidism, pregnancy, and some medications like estrogen or tamoxifen. Pancreatitis can be caused as a complication of ERCP. So endoscopic retrograde cholangiopancreatography is done to remove gallstones or to cut the sphincter as a treatment of stones in CVD, but this can itself cause pancreatitis sometimes, and some people have a genetic predisposition for pancreatitis. Medications in less than 5% cases of pancreatitis are the cause. There could be various mechanisms and accordingly the drugs. Immunologic like mercaptopurine or aminosalicylates or sulfonamides, direct toxic effects, diuretics, sulfonamides, accumulation of toxic metabolites, valproic acid, pentamidine, tetracycline, overstimulation of acinar cells, GL1 receptor antagonist, ischemia, diuretics, azathioprine, intravascular thrombosis, estrogens, and increased viscosity of pancreatic juice, diuretics. So from this chart you can see that diuretics can cause pancreatitis via 3 different mechanisms. So diuretics, estrogens, and some drugs, azathioprine and sulfonamides, can make the patient prone for acute pancreatitis. Sometimes pancreatic duct injury can cause pancreatitis during surgery. Biliary sludge. Biliary sludge means there is a sand-like substance in the gallbladder, no stone per se. Biliary sludge is found in 20 to 40% of patients with acute pancreatitis with no obvious cause. So in the absence of any other etiology, biliary sludge should be suspected as a cause of pancreatitis with acute pancreatitis with a transient elevation of liver enzymes. So if you don't find any stone but you have a transient elevation of liver enzymes with acute pancreatitis, probably biliary sludge is the cause. Biliary obstruction by worms, periampullary diverticula or periampullary tumors can cause pancreatitis. Sometimes autoimmune pancreatitis type 1 and type 2, these are rare. The presentation is weight loss, jaundice, pancreatic enlargement, and pancreatic enlargement here mimics a neoplasm. So this is reasonably rare. Lastly, hypercalcemia can cause acute pancreatitis. Pancreatitis can also be caused by a variety of infections and toxins like viruses, mumps, Coxsackie, cytomegalovirus, herpes simplex, and HIV, and even COVID-19. Bacteria, most commonly Mycoplasma, Legionella, Leptospira, Salmonella. Fungi like Aspergillus, and parasites like Toxoplasma, Cryptosporidium, and Ascaris. It can be also caused rarely by vascular disease. Like patient with SLE or polyarthritis nodosa. There could be some anatomic or physiologic pancreatic abnormalities like biliary cyst, and in 20 to 30% of patients, no appropriate cause can be found in cases of acute pancreatitis. So these are the idiopathic cases. Now, how do we diagnose a case of pancreatitis? So if 2 of these 3 findings are present, you can easily diagnose a patient of acute pancreatitis. First is upper abdominal pain. Second is increase in serum amylase or lipase or both more than 3 times of upper limit of normal. And characteristic finding in abdominal imaging, CT, MRCP or ultrasonography. Whenever you suspect acute pancreatitis, you have to have a history of first thing is prior symptoms of gallstone disease, like documentation of gallstones in a prior ultrasonography, or are there any systemic symptoms like weight loss or new onset diabetes. If you suspect alcoholic pancreatitis, inquire about the amount and pattern of alcohol use. For example, at least 5 years of heavy alcohol consumption is required, that is more than 50 grams per day is required to cause acute pancreatitis. Medication use, especially estrogen, sulfonamides and diuretics. In this case, also see whether the patient has any rash or eosinophilia. Prior surgery, especially ERCP or abdominal trauma. History of hypertriglyceridemia. So if the patient has significant history of hypertriglyceridemia, you can suspect hypertriglyceridemic pancreatitis. If there are concomitant autoimmune disease, then the patient could have autoimmune pancreatitis, SLE, you get ANA and all those tests done. And lastly, if there is family history of recurrent pancreatitis, so you should suspect familial pancreatitis. So what are the investigation you advise? CBC to see for hematocrit and leukocytosis. Amylase and lipase are the main investigations, we'll come to it. Kidney function test, urea, creatinine and BUN. BUN is very important in acute pancreatitis to see the status of hydration. We will come to it. Liver function test, if the liver function test, especially ALT, is more than 3 times of upper limit of normal in gallstones, so that helps in diagnosis. Blood sugar to see for hyperglycemia, serum calcium for hyper or hypocalcemia, lipid profile to see for hypertriglyceridemia, ABG to see for hypoxemia. Hypoxemia can be due to pleural effusion or it could herald an onset of ARDS. Ultrasonography to see for gallstones, bile duct dilatation and the pancreatic anatomy. And lastly, contrast enhanced CT abdomen for precise information on pancreatic anatomy. And lastly, MRI and MRCP. So serum amylase and lipase are the 2 investigations that we get done in any patient of acute pancreatitis or any patient with upper abdominal or epigastric pain and you suspect acute pancreatitis. So you should have a basic idea of amylase and lipase. Amylase rises within 6 to 12 hours of onset of acute pancreatitis and it has a very short half-life. So it of approximately 10 hours. And in uncomplicated attacks returns to normal within 3 to 5 days. Serum amylase elevation of more than 3 times upper limit of normal. So if the upper limit of normal is say 40, if the serum amylase is more than 120, then it has a sensitivity of 67 to 83% and a specificity of 85 to 98% of diagnosing acute pancreatitis. Importantly, elevations more than 3 times upper limit of normal may not be seen in 20% of patients with alcoholic pancreatitis. So amylase is predominantly seen specifically in gallstone pancreatitis. In alcoholic pancreatitis, in about 20% of patients, they may not have rise in amylase. In 50% of patients with hypertriglyceridemia associated pancreatitis, amylase may not be raised because triglycerides interfere with amylase assay. Importantly, given the short half-life of amylase, the diagnosis of acute pancreatitis may be missed in patients who present more than 24 hours after abdominal pain of acute pancreatitis. Lastly, serum amylase may be normal on admission in 20% patients of acute pancreatitis. So, a normal serum amylase does not necessarily rule out pancreatitis. Amylase can be raised in various different causes. So any pancreatic problem, pancreatitis, trauma, surgery, ERCP, duct obstruction, CA pancreas or complications of pancreatitis like pseudocyst can raise amylase. Any problem with the salivary gland, infection, trauma, radiation, duct obstruction. Any problem with the GI tract, peptic perforation, peptic ulcer, any obstruction, mesenteric infarction, cholecystitis, appendicitis, liver disease. So any GI tract pathology can also cause raised amylase. Gynecological causes, ectopic pregnancy, ovarian fallopian cyst, and even pelvic inflammatory disease can cause raised amylase. Some neoplasm, especially tumors of lungs, breast, prostate, esophagus, thymus, and multiple myeloma and pheochromocytoma can cause raised amylase. Renal failure can cause raised amylase. So, in patients with renal failure or CKD, amylase does not become specific. Amylase can rise in pregnancy, AIDS and COVID. Some drugs can also cause raised amylase. And aortic aneurysm, severe epigastric pain can be a presentation of aortic aneurysm also, but aortic aneurysm also can give rise to raised amylase. So, post-operatively amylase can be raised, even cerebral trauma or MI. So, diverse conditions can cause raised amylase. So, amylase is by no means very specific. Lipase is a little more specific and more useful. Sensitivity is 82 to 100%. It rises within 4 to 8 hours of onset of symptoms and peaks at 24 hours and returns to normal within 8 to 14 days. So, we have time of 1 to 2 weeks when a lipase remains elevated. Lipase elevation can occur earlier and last longer than amylase. Therefore, lipase elevation is especially useful in patients who present more than 24 hours after the pain. Use lipase assay alone or in combination with amylase. We as a policy routinely use amylase plus lipase. Like I just said, in patients with renal failure, elevated amylase may be a false positive. Serum lipase is also more sensitive compared to amylase in patients with pancreatitis secondary to alcohol. In alcoholic pancreatitis, as we just discussed, in 20% of patients, there may not be raised amylase. So, if the lipase is raised more than 3 times upper limit of normal, this could be helpful. As you can see from this diagram, within 4 to 6 hours, amylase rises, reaches maximum in about 12 hours, and by 1 to 2 days, it has returned to normal. While lipase rises equally fast, the peak comes a little later, but it remains elevated for 1 to 2 weeks or sometimes even longer. So, lipase is equally or slightly more important than amylase in diagnosing pancreatitis. Contrast enhanced abdominal CT is very useful. I would say CT would be best done after 72 hours of severe acute pancreatitis, because this is the time that is usually required to evolve the full picture in CT. But if there is diagnostic dilemma, you can get CT on presentation also. Should be performed if MRCP and endoscopic ultrasound are unavailable. On a CT, normal pancreas is seen as an area of homogeneous density with smooth contours and with regular contrast enhancement. Diagnostic clues to acute pancreatitis on a CT scan, preferably done more than 72 hours after the onset of symptoms, include pancreatic swelling. You can see the pancreas has swollen. Areas of spontaneous attenuation in the gland. So, you can see that some more whitish areas while others are darkish, and areas which lack enhancement during the bolus IV. So, there are some areas which are not enhancing. These are probably representing the necrosis, and there is peripancreatic fluid collection. So, this is peripancreatic fluid collection. So, if these signs are present together with typical abdominal pain, this is very suggestive of acute pancreatitis. When the dilemma persists, when the patient is presenting like acute abdomen, when in doubt, you can use ultrasound guided peritoneal aspiration. If the fluid gram stain suggests bacteria, if the bacteria or the counts are raised, it is unlikely that the patient has pancreatitis. But if the fluid is rich in amylase, it could be of help in diagnosing acute pancreatitis. So, till now we have seen what are the causes of acute pancreatitis, what are the symptoms, what is the presentation, what are the clinical examination findings, what are the investigations that we normally get done in acute pancreatitis. In the next lecture, we would talk about the Atlanta classification and how we divide the pancreatitis into mild, moderate or severe, and then we will go ahead with the treatment. Thank you so much.